Welcome to everyone who is on the webinar right now, and we'll still, I believe, have a few more people joining later. But this is the KDIGO series, a decade in the making, optimizing the holistic approach to the evaluation and management of CKD. And I am, excuse me. I'm delighted to welcome you all here today to the third of our 5 webinars, and today's topic is Personalizing Our Approach, a focus on the diagnosis and prognosis of CKD. So just to introduce myself, my name is Sofia Ahmed. I'm a nephrologist and a professor in the Faculty of Medicine and Dentistry at the University of Alberta in Canada. And I'm delighted to be here today with my colleague, Professor Michael Shlipak, an Associate Chief of Medicine for Research in San Francisco, the VA Medical Center, and a professor of medicine at the University of California. And we were both part of the work group who contributed to the 2024 KDIGO evaluation and management of the CKD guidelines. So just to give you an idea what we'll be discussing over the next 30 minutes or so, obviously we're welcoming you here today. After we go through that, then Professor Shlipak will go through actually 2 interactive case studies in CKD, where we will ask for your input as well, so be prepared for that. We'll finish with a short panel discussion, and I encourage you to put your questions throughout the talk into the Q&A, and we will do our best to address them. And then we'll finish off. So just before I pass the microphone to Professor Shlipak, I just would like to highlight our learning objectives. And so first, we'll review the comorbidities that indicate testing for CKD, or when they should occur. We will outline the recommended diagnostic tests to confirm a CKD diagnosis. And as I said earlier, we will utilize patient cases to define and classify CKD and predict patient prognosis. So as I said, before I do pass on the microphone to my colleague, as you will recognize on your own computer, your microphones and cameras have been disabled for the duration of the webinar. This meeting is being recorded so that it is available for on-demand use if you'd like to look at it again, or any of your colleagues. And as I said, please submit questions. We really are interested to hear from you, and we'll answer as many as we can during the time permitted and respond to the rest offline. And if you have any technical concerns, please submit queries also using the Q&A feature. So without further ado, I'll pass the microphone to Dr. Shlipak. Thank you.
Hi, everyone. Hopefully you're hearing me okay. And the slide will advance. Okay, so our first case study is Hilda. And Hilda is a slide below this. Is a 72-year-old woman. She has long-standing hypertension for 15 years. She had a heart attack a year ago, and she is a former smoker who stopped about 10 years ago. I need you to advance the slides for me. I don't know why. For medications, she's on an ACE inhibitor, she's on a thiazide diuretic, and she's on a high-potency statin. And for her labs, as you see below, she has normal BMI, her blood pressure is borderline, and her cholesterol is well controlled. So first of all, the guidelines, the new guidelines, and those of ISN, KDIGO, WNCA, all recommend that patients with hypertension should be screened for CKD. And I want to just pin the word screen for a second. Often the word screening means population-based, untargeted testing. In this case, when we say screening, we're really referring to case finding among people at risk. And so persons at risk for CKD include the following conditions, 2 of which Hilda has: hypertension, which she has; diabetes, she does not have; cardiovascular disease, she has. And then other factors that might influence testing include older age. And at 72 years old, she would qualify for testing for that as well. So my ability to advance the slides is not active. There we go. Going. And so the summary in the guideline is that the initiation and frequency of CKD testing should be individualized based on the kidney and cardiovascular risk profiles of patients and their individual preferences. Our next case is Emmanuel. Emmanuel is 53 years old. He's about 2 decades younger than Hilda, and yet he's already had hypertension diagnosed 5 years ago. He's had diabetes since the age of 50, and he's on a series of great medications. He's on 3 medications for his diabetes. He's on an ARB for blood pressure control, and he's also on a high-potency statin. And these are his labs below. He's overweight. His blood pressure is at 134/82, and his diabetes and lipids seem reasonably well controlled. So because he has diabetes, he automatically also should be tested for CKD. And so his reasons to be tested include his diabetes, his hypertension, and we can go to the next slide. So our question for you all is, how often do you screen patients who you would consider to be at risk of developing CKD? Would it be at least annually? Would it be once every year and a half, every 2 years, every 3+ years, or never? And please respond. Excellent. So about 90% of you said at least annually. A few of you said 11%. And what is really gratifying to me is that none of you said never. And I think based on the individual patient, any of the top 4 responses could probably be considered correct. So my rule of thumb would be we must test and get a baseline for patients who have any of these risk conditions for CKD. If they test negative, then how often we repeat testing is really individualized based on how close they were to the borderline of CKD. And if they have either test abnormal, then we go into annual testing. So what we see before us is the screenshot from the guideline on the algorithm for testing. And really the important points are in the top left. When we test for CKD, we always use estimated GFR, which is measured by a blood test, and we use albuminuria, which is measured by a urine test. And there's really 2 key numbers you need to know. Under 60 milliliters per minute for GFR defines CKD, less than 60. And for albuminuria, over 30 defines CKD. And under 60 eGFR, worsening eGFR is worsening CKD. And with the albuminuria, as it gets higher and higher above 30, that's also worsening. So to dive into that a little further on the GFR, so on the left is the algorithm on testing of creatinine and cystatin C, and then measure GFR. And here are the key points. Let's start with creatinine, which you're probably all familiar with. The recommended initial test for GFR estimation is the creatinine, the eGFR creatinine. It's available in most patients because creatinine is routinely measured as part of the basic metabolic panel that most of your patients will get. But because creatinine comes from muscle and diet, the eGFR creatinine is often biased in persons with abnormal levels of activity. That can be low activity for sedentary persons or high activity, think bodybuilders or distance runners. Creatinine is also can be biased in people with severe illness or multimorbidity and persons with malnutrition. And in such patients where creatinine you think might not be right, consider the combined eGFR creatinine and cystatin C, or the eGFR cystatin, or the measured GFR. So let's talk a little more about cystatin C, when to measure it. So cystatin C is a blood test like creatinine. It's an automated test, and we can use it in combination with creatinine for a combined eGFR, and that is used for the initial staging of CKD. I want to pause there because this is new with the 2024 guideline. Before, we always staged with eGFR creatinine, and now we're saying that really to get the optimal staging, we need the combined equation, which means that you will need to learn how to order a cystatin C blood test. We also recommend the combined equation when a more accurate assessment of GFR is needed for clinical decision-making, and that might be drug dosing of a nephrotoxic medication. And then finally, measured GFR. So GFR can be measured directly using plasma or urinary clearance of an exogenous filtration marker. Exogenous means something that's inserted or infused into the body. Think radiology contrast agents are often used for this purpose. It's about a 4 to 6 hour test because we measure the time in which the substance that we put into the body is cleared by the kidneys. So when available, we recommend using measured GFR when a more accurate assessment of GFR is needed for clinical decision-making, and both creatinine and cystatin C are expected to be inaccurate. Now, many places do not have measured GFR available, but we are hoping that it will become more available in the future. So KDIGO provides tools to define and classify CKD and illustrate the downward trend of patient prognosis with worsening CKD stages. So first of all, CKD is defined by abnormalities of kidney structure, that's the albuminuria usually, or function, and that's the GFR we were just talking about. The chronic means 3 months or longer, and with implications for health, meaning that we're really diagnosing CKD because it matters to the patient and their prognosis. We classify CKD on this CGA system. C is cause, G for GFR, and A for albuminuria. And prognosis of CKD is based on the GFR and albuminuria categories. And we'll show that in this heat map. Hopefully some of you have seen this before. Now, in the old days, and this is really the 20-year-old guidelines, we only used GFR categories for CKD staging, CKD3, CKD4. Now, when we talk about the staging of GFR, you must use the GFR category going down the rows and the albuminuria categories going across the columns. Now, as an example, if you look at the G3A category, the 45 to 59, notice that if it's A1, it's a light yellow, meaning moderate risk. And if it's an A3, it's very high risk, which just illustrates that the GFR alone category does not give us enough information about CKD staging. So we need to use both. Okay, so now we're going to stage our two sample patients. Hilda, we measure her eGFR, and it's 43. Her albuminuria is at 150 milligrams per gram. That puts her CKD stage as a G3B and an A2. And you can see her box there. And for Emmanuel, his EGFR is a bit better at 56, so he's a 3A. And his albuminuria stage at 40 also puts him in the A2, although not as high in that stage as Hilda. Now, his CKD stage is more favorable than Hilda, but the fact that he's 20 years younger, he's probably at higher lifetime risk of progressive CKD. Now, these slides illustrate cardiovascular mortality risk based on EGFR in the left curve and based on albuminuria in the right curve. The blue lines are for persons without diabetes and the green for those with diabetes. So let's just illustrate where Hilda and Emmanuel fit. So Hilda, because she has non-diabetes, we're using the blue curves, and her EGFR puts her at about a 1.7-fold risk, and her albuminuria puts her at about a doubling in risk. So relative to a similar woman at her age, these two kidney factors multiply her cardiovascular risk by over 3-fold. It's even more dramatic for Emmanuel because he already has diabetes, which is an important risk factor. His EGFR doubles his risk, his albuminuria triples his risk. So relative to a non-diabetic, similarly aged man, he's at 6-fold risk of cardiovascular mortality. Okay, so the KFRE, that's the Kidney Failure Risk Equation website, which is in the footnote of this slide, predicts the 2- and 5-year risk of progression to kidney failure requiring dialysis or transplant. And notice these are relatively short-term risks. These are kind of these are not lifetime risks of kidney failure. And so Hilda's risk at 5 years is 1.6%, and that's moderate CKD. And it's important to note that guidance on referral to nephrology care is between 3% and 5% at 5 years. So what that means is, even though Hilda has moderate CKD, she's still in the range that's being treated by primary care. Other indications for nephrology referral would be an EGFR less than 30 or an albuminuria over 300. Now, Emmanuel's kidney failure risk looks quite low at 5 years, but because he's only 53 years old, 20 years younger than Hilda, his lifetime risk is probably higher than Hilda's for kidney failure. More importantly, both of these individuals have very high cardiovascular risk. The figure on the left shows the traditional the traditional risk factors for cardiovascular disease and the additions of albuminuria and EGFR with that. This is for the PREVENT equation that we'll show on the next slide. And on the right, what we're showing is that based on the number of cardiovascular risk factors, risk goes up, but the benefit of treatment also increases. So there's a huge bang for the buck, if you will, a huge attributable benefit if we treat persons who are at the highest risk. So that brings us to how high a risk for cardiovascular disease are Hilda and Emmanuel. So Hilda, these are her various inputs that go into the PREVENT equation. And her cardiovascular disease risk at 10 years is 29%. And notice that her heart failure risk is actually quite a bit higher than her stroke, heart attack risk. And this is true for all people with chronic kidney disease. Heart failure is really the dominant cardiovascular risk that they have. Now, in fairness, Hilda's risk is actually probably even higher because she's already had a heart attack a year ago. Now, Emmanuel's risk, remember, he's middle-aged, and yet he still has pretty high risk of cardiovascular disease. And again, heart failure is a higher risk than his atherosclerotic risk. If we were to show his 30-year risk, which can be determined on this calculator as well, that would be substantially higher. And so these numbers relative to the kidney failure risk really emphasize that when we treat patients with chronic kidney disease, managing their cardiovascular risk is really a top priority, as much as limiting their risk for progressing to advanced stages of kidney disease and kidney failure. All right, that is the end of our 2 cases.
Wonderful. Okay, well, thank you very much for that excellent presentation. So the questions are coming in fast and furious, and please bring those, keep them coming. But maybe I'll start with one of them is an appreciation for the 2 cases that you presented and highlighting the differences between the 2 individuals. And so, and they wondered about other personalized or more other factors that could be taken into account in the clinic. And so actually, maybe I'll speak to that. And, there are 2 topics that we really didn't have the opportunity to address, and that would be activity levels and diet as the first one. And so it is important, the advice that's given in the KDIGO guidelines is really, I'll use the word the optimal advice and then the perfect scenario, but it is important that we adapt that to our local conditions and certainly to the person in front of us, taking into account their personal circumstances, their values and wishes. And as I said, that activity and diet play a huge role in all our lives. And so it's important to take that into account too when we're calculating a person's balancing their kidney risk and cardiovascular risk, in the context of their own life. And the other factor that we didn't have a chance to talk about are, the life phase of a person and how that changes as we all age. And so, for example, female reproductive health, we need to ask our patients, do they have an interest in becoming pregnant? And if so, we need to talk to them about that, because we don't want to have an unplanned pregnancy, because that certainly does change their kidney and cardiovascular risk. Conversely, we need to know if they don't want to become pregnant and talk to them about different forms of contraception, for example. Certainly our transgender and gender diverse patient population, we need to recognize that sex assigned at birth isn't always the same as a person's gender identity. And that actually is a great lead into our next question, which Dr. Shlipak, you had talked about evaluation of GFR using creatinine, and in specific cases, cystatin. And in other cases, it might be most appropriate to do measured GFR. And so I wondered if you could speak a little bit to that and what might be some examples that you can think of where those different scenarios may be appropriate.
Yeah. So let me start with I'll start with the caveat of I've never used measured GFR. We don't have it either at the VA hospital or at UCSF where I've practiced. We do hope that because it's an unbiased test, that it will become available more in the future. Cystatin C, however, we've had at my hospital for 12 years. So I have over a decade experience of being able to use a simple blood test as a second opinion for creatinine. And I am always surprised by how often they differ from one another. And initially, we sort of imagine that we can guess that if someone's really large or really small, that their creatinine would be different from perhaps a measured GFR or from cystatin C, which is unbiased by muscle. But more and more, I think in any high-risk situation, in patients where we actually care about kidney function, that it's helpful to use the cystatin C for a second opinion. And you can either have the 2 separate eGFRs and use your own intuition on which one is least likely biased, or you can average the 2 together, which is essentially what the combined equation is. We're also using it quite a bit in the hospital where patients are obviously immobile.
Okay, well, thank you for that. And actually, the next question leads quite well into the next question, which is could you comment on point of care testing? What you've described are very clinic and hospital, based. testing. Could you talk about point of care testing?
So
And
point of care testing was reviewed in our current guideline. And we believe there is an important role for point of care testing for patients who don't have a lab available. That could be in remote areas or areas that just lack lab facilities. The point of care tests themselves, I think, vary in their accuracy, and I could not summarize that here. But I think they are not a replacement for in-facility labs, but I think a complementary approach when patients and labs just aren't in the same place.
it's great. No, thank you. So then there's a question about we talked about the CGA classification of kidney disease, and so cause, the GFR, as well as the albuminuria. And so there was just a question about where does cause fit into the table presented? And I don't know if you want to talk about that or, go ahead.
Probably both. I'll just start with, ideally, we would have that, that albuminuria by GFR risk separately for every cause of kidney disease, because they are all quite different. But epidemiology has not permitted that. And so clearly progression differs by cause. In terms of the evaluation for cause, do you want to comment as a nephrologist on how you approach, the diagnosis and maybe whether we should be doing biopsies more than we do?
Absolutely. So, biopsies are, as we outlined in the guideline, are safe. And of course, with any procedure, there are chances for complications, but overall, they actually are a very effective diagnostic tool. And in many cases, incredibly important because they do direct management, which can be quite different depending on the cause. I think what we want to get at having the CGA classification is that it just allows for a different interpretation, and whether additional treatment should be added on top of, I'll use the word armamentarium in terms of treatment of CKD. So for example, someone who has CKD that is secondary to diabetic kidney disease will have a very different treatment than someone, for example, who has CKD secondary to lupus. And so it's very important that we don't just use the word CKD, but we highlight what either the presumed cause is in the absence of a biopsy, or that we actually biopsy the person. And certainly the other, back to history and physical, the history, accompanying labs, the physical examination findings can all point us in one direction versus another as to the cause of CKD. So this actually brings us to really the end of our question session. And I'm sorry, there are so many questions that we just were not able to get to. I'd like to thank Dr. Shlipak for that outstanding presentation. And just to thank the audience for coming today and your tremendous questions. We will attempt to answer those offline. I'd like to remind everyone that this is only the third of 5 webinars presented by KDIGO, and our 4th and 5th are listed, as you can see, on the 7th and 22nd of May, respectively. We'd be delighted if you would register for them, and the links for that are in the chat right now. So with that, I would once again like to thank Dr. Shlipak, thank the organizers, and most importantly, thank the audience. And we'll take care of our people together. All right, thanks very much. Wishing you a great day.